I can go. Okay, thanks. So, good evening, everybody. I welcome you all to this webinar, which we also call as eGurukul, hosted by IndiaBull Pharma. So, I'm myself, Dr. Abhay Mane from IndiaBull's medical team. And we wanted to actually have this webinar or e-webinar given the current situation of corona pandemic. So, we have also kept the today's topic very relevant. And a bit about IndiaBull Pharma. Also, I would like to say that currently we are in the 100th rank in India. We are 3-year-old pharmaceutical company, and we have a ambition of going up to 25th rank in next 5 years. So we have these two divisions, Orion and Vesta division, which look after the chronic cluster, the chronic segment. And we also take science very seriously. So today's eGurukul is also one of such initiatives. We have two eminent speakers today here with us. So our first speaker for today is Dr. R.K. Sahai, who is an endocrinologist, a renowned one from Hyderabad. He runs his clinic as Dr. Sahai's Diabetology Center, and he's also a head of endocrinology in the Osmania Medical College. So we are very privileged to have you here today. And can you please take us through the first topic for today, which is the management of diabetes in the COVID pandemic? Welcome, sir, once again.
Yeah, thank you, Dr. Abhay, and warm welcome to all those who are attending this webinar. And thank you to IndiaBulls for organizing this webinar in this times of COVID, when all of us are bound to our homes, and for giving us this opportunity to interact with each other. So I will discuss about the management of diabetes during this period, because what we see is that one second, let me just share my screen. Yeah. So I will try to speak about the management of diabetes during this COVID pandemic, and what are the implications. What I have done is that I've divided my talk into three different headings. I would discuss about the pandemic as such. Just give you a brief outline. I'm sure all of you are very much aware of the pandemic. Everybody is reading a lot nowadays, and keeping themselves up to date with what is happening with regard to the numbers across the world and across the country, what is happening. So everybody is quite familiar with that. So I'll just give you a brief outline of what is happening, and then discuss about the correlation between diabetes and COVID, and then give some practical recommendations. So that's what I'll try to do. Very briefly, I'll be discussing these aspects. So if you look at the management of diabetes during this, if you look at the problem as the pandemic as such, we know that we are going through this unprecedented outbreak of coronavirus disease, which has started somewhere in December. All of us became aware of it in February, and it's only in February that it reached that pandemic status. And what we are worried about is that it is going to affect a large percentage of the population, whether it is already done so or not. It is going to infect a large percentage of our population, and until we develop a herd immunity for this virus. And most people who have comorbidities, they tend to have a more significant problem with this pandemic, and they have worse outcomes. So that's why we are worried about diabetes and cardiovascular disease. So these are the major comorbidities that are present in the population, and these are the ones which have been shown to have a sort of a poorer prognosis in terms of the outcomes of people who are affected with this infection. So that's why we are discussing that, and what we are also seeing that is that COVID infection also, hyperglycemia has a adverse impact on the COVID outcomes. And also what we're seeing is that COVID itself, infection itself, can cause hyperglycemia, particularly in older patients. So this is what we are going to do. This is what I'll try to discuss in the next few minutes. So if we look at diabetes and COVID, diabetes is a major, most important comorbidity linked to the coronavirus disease, because of the fact that diabetes is very common. In the population, we know that at least 10 to 12% of the population is affected by diabetes. In India, we have almost 70 million people, more than 70 million people. Today, it is probably close to 80 million people with diabetes, and it is but natural that many of them are going to get infected with the virus. And what we see is that patients with diabetes have an increased risk of complications, including ARDS and multi-organ failure, and they tend to have a poorer outcome. And what we have seen, I mean, although it is from the data that is accumulated from places which have had a significant degree of infection, that is from Wuhan and from Italy and from other places where we have had the initial reports and initial publications that have come up till now. What we have seen is that if you look at the number of people infected with the virus or having COVID-19 disease, we see that the numbers in terms of diabetics versus non-diabetics is not very different. But when you look at the outcomes, we find that diabetics are overrepresented amongst the people who have poorer outcomes. So that is what we need to understand. And why does this happen? Because diabetes has significant impact on the neutrophilic and on the function of the innate immunity. It interferes with the neutrophil phagocytosis, neutrophil chemotaxis, and also the T cell mediated immunity, the T cell mediated immunity. So diabetes has a impact on all these aspects of immunity, and because of that, what happens is that the infection tends to be more severe in people with diabetes. And what we see is that diabetes was also identified even in the related epidemic of the MERS, or the Middle East respiratory syndrome, which happened a few years back. Um, there also, what we found was that diabetes was identified to be major comorbidity. And diabetes, as such, we know that diabetes is a risk factor for development of severe pneumonia, and whenever there's any viral infection, also they tend to be a little more severe in patients with diabetes. So, as such, the chance of developing the disease it depends on the exposure and various other factors. But once a person with diabetes contracts the illness, then he tends to have a more severe illness. And why? What are the mechanisms for that? We know that the virus has got a corona shape. I mean, it's called coronavirus because it's got this crown-shaped appearance, and it has got a lot of these spicules. I'm sure you're seeing all these pictures of the virus everywhere, and we know that it has got these S protein present in the spicules, in the spikes, and that S protein serves as a protein for entry of the virus into the cell. And how does it enter into the cell? It enters through this binding to this ACE2 protein. ACE2 protein serves as a receptor for binding to this S protein, or the virus binds to that, and then it causes entry of the virus into the cells that contain this that have this ACE2 protein on their cell surface. It was also thought that particularly for the MERS virus, what was seen was that the DPP4 enzyme served as a functional receptor for the MERS protein virus. But it's not been shown very clearly for the COVID-19 virus, which is, although they are very similar viruses, but it has not been clearly shown with this. But this could also serve as a functional receptor, the DPP4 enzyme, and hence people who are using DPP4 inhibitors are probably sort of more favorably affected in terms of the entry of virus being limited by the use of DPP4 inhibitors. That's something which has been postulated, which has not been very clearly shown as yet. We don't have evidence or data for that as yet, but it is very clearly seen that that the ACE2 protein does serve as a receptor for this virus. So, to gain entry into the cell, the SARS-CoV-2 virus, as this virus is called, hijacks an endocrine pathway. The endocrine pathway is this ACE pathway. The angiotensin converting enzyme 2 has been identified as a receptor for the coronavirus spike protein. And ACE2 as such is, as you know, in the ACE pathway, there is conversion of this angiotensin 1 to angiotensin 2. And the angiotensin 2 has got these vasoconstrictive properties and all the other properties that has on the vascular wall. And we use ACE inhibitors to reduce the levels of this angiotensin converting enzyme. And when you use ACE inhibitors, it has been shown that there is upregulation of this ACE2 protein. ACE2 protein has, and ACE2 itself has been found to have protective effects with regard to inflammation. But the upregulation in what is postulated was that this upregulated ACE2 protein may serve as may enhance the entry of the virus into the cells. That was what was a major concern which was there, and there was a lot of debate on that, discussion on that, on whether the use of drugs like the RAS blockers, that is either the ACE inhibitors or the ARBs, which actually increase the expression of the ACE2 receptor, ACE2 protein, whether they would have a detrimental effect in terms of increasing the risk for virus entry into the cells. But this has been clearly shown. Even before the evidence came out, all the professional organizations recommended that we should continue using the ARBs. We shouldn't stop them because the benefits that they provide are much more than the postulated harm that was seen. But there was data again. Then a lot of the initial data that has accumulated has looked at has looked at the comparison between those taking ARBs versus those who are not on this medicine, and the risk and the severity of infection. And it has been clearly shown that there's no difference between that. So this was a recent paper which came out in the NEJM, so that clarified the stand that has been taken by or ratified the stand that was taken by most of the professional organizations. And today, all of us can confidently recommend all our patients to continue taking ACE inhibitors, ARBs. And so that's one aspect of the problem that we are discussing. Now, coming to the picture of as I was mentioning, that this is just showing us a diagram of the virus and how the spike protein, as you can see there on the red, binds to the ACE2 protein, which is present on the surface of some of the cells. And the cells which have a lot of these ACE2 protein are the pneumocytes, and then it's also present in the vascular, in the endothelium, and it's also seen to be present in the kidney and also in the pancreas, also in the islet cells of pancreas. So that's how this protein serves as a receptor for the entry of the virus. Now, with COVID-19 infection, probably there is reduction in the ACE2 expression, and because of that, there is cellular damage, there is initiation of the intense inflammatory response, which is responsible for the causation of respiratory failure. And there's also another aspect that has been shown in several autopsy studies, that there is a lot of prothrombotic state which is created by the virus, and there is this intravascular coagulation which is happening, and suggesting the need for use of medications, the anticoagulants having an important role to play in the management of this disease. Now, acute hyperglycemia causes upregulation of the ACE2 expression, and that thereby again may facilitate the virus entry into cells. Apart from the other mechanisms that we have said, that hyperglycemia, how it interferes with the immune functions and can have an impact on the severity of the infection. Apart from this, it has also been shown in experimental studies that acute hyperglycemia causes upregulation of the ACE2 expression, and which may facilitate again the viral entry. Then, while chronic hyperglycemia can cause downregulation of the ACE2 expression, but however, the cells are more vulnerable to damage by the virus. So both acute or chronic hyperglycemia is not very good, and we need to look at maintaining our patients at good glycemic targets, so as to see that the outcomes are better if they get infected. If you look at the DPP4 pathway, as I was mentioning, it was identified as a functional receptor for the MERS virus, that is the Middle East respiratory syndrome virus, which is very similar to the coronavirus. And DPP4 enzyme also increases inflammation in type 2 diabetes. So that's why the DPP4 inhibitors have an anti-inflammatory effect and have a favorable effect on the inflammation. While we know that the one of the important side effects of DPP-4 inhibitors, if you look at it, was nasopharyngitis in most of the earlier studies. But it has been shown that DPP-4 inhibitors have a favorable effect on inflammation, and if anything, they may be helpful in terms of preventing the virus entry and replication. So it has been, although it has not been clearly shown that the same enzyme works as a functional receptor for this particular virus, but the related virus which was earlier causing the MERS epidemic did it was clearly shown that the DPP4 pathway was being used for the entry of the virus into the cell. Now, how the how these mechanisms exactly affect the diabetes management is not very clear, but we should know that these mechanisms are affected by the virus infection, and we should see how we can favorably utilize this for the management of our patients. Now, what are the possible reasons for the poorer outcomes of diabetes? I mean, of diabetic patients in this COVID infection. The reasons could be multiple. I mean, as you can see on this slide, we have all the reasons listed out. Apart from the what we discussed earlier, that diabetes has the effect on the immune functions. Apart from that, the glucose levels, when the glucose levels are increased, they can in the alveolar secretions, they increase the influenza virus replication. This has been shown in influenza virus infections. And then animal models of diabetes have shown that have also revealed that collapsed alveolar epithelium and increased vascular permeability to be correlated with the diabetes, the level of hyperglycemia. And it is also, as I mentioned earlier, that diabetes is also correlated to the ACE2 expression, that is acute hyperglycemia, causing increase in ACE2 expression on the cell of the pneumocytes, causing increased entry of the virus. And it is also seen that diabetes is associated with increased furin, which is a type 1 membrane bound protease, which belongs to the PCSK family and is involved in coronavirus entry into the cell. So this is also which has been seen. As you could recollect in the picture that we saw earlier, we saw that just next to the ACE2 protein was a furin protein. So that also can serve as a sort of receptor for the entry of the virus into the cell, and that is associated with, hyperglycemia is associated with increase in the furin also. And apart from that, hyperglycemia also influences the secretion of other cytokines like IL-6 and CD4 ratios are altered by hyperglycemia, and that also can have an impact on the response to the virus infection. So, because of this, what we have seen is that we need to sort of try to see that the patients are optimal managed, because diabetes, when it's present, if it is optimally managed, probably the outcomes may be better. So, but we'll look into what is the evidence for all that. We'll come back to that a little later. But when should we suspect COVID infection? Because very often, when there could be cold and flu also, and what are the symptoms? Although many times the infection can be asymptomatic also. About 70-80% of patients may be asymptomatic also, may have a mild infection. But what are the features of this mild infection which are differentiating them from common cold or flu? As we can see, what happens here is that the time, the incubation period is generally about 2 to 14 days from the time of exposure, and the symptoms generally last for about 2 weeks or so. And in those who have more severe disease or critical disease, and if they recover from that, they may take about 3 to 6 weeks to recover completely. And fever is very common. And what we also see is that cough and respiratory distress are common. I mean, or difficulty in breathing. These are more common, which are not so often seen in patients who have got cold or flu. They may not develop fever, but they may just have a little soreness in throat, and they may have just a little tiredness and all that. So more than that, in the patients who develop COVID infection, they tend to have breathing difficulties. They have fever. They have and these are the symptoms which should alert us to look for test these individuals. Now, what are the precautions that you would advise in people who are affected? those who are diabetic, we would advise them to take plenty of fluids, and advise them to sort of see that they remain well hydrated. Second thing, what we would advise them is that they should do frequent self-monitoring of blood glucose, and we need to see that they don't have very severe hyperglycemia. And at the same time, we should see that they don't go into hypoglycemia also. That can also be harmful for such people, for people with diabetes. And particularly those with type 1 diabetes should be advised to check their urine ketone levels also, because very severe hyperglycemia has been seen to occur in patients with COVID infection. It has been reported from several places across the world, from the US, from many centers in the US have reported very severe hyperglycemia in patients with COVID infection, and they've postulated that there is a virus entry into the islet cells, that is saying that there is direct insulitis or the islet cells being directly affected by the virus infection, and that is causing decline in the insulin secretion, and also a severe insulin resistance has been noted in these patients who are affected by COVID-19. Then what we find is that there is decrease in lymphocyte count, and decreased hemoglobin levels, increased CRP levels, and increased LDH levels and D-dimer levels. Particularly when you find these increase in D-dimer levels and increase in the AST, ALT, and the cardiac biomarkers, then that is an indicator of more severe infection, increased LDH levels also. So these are indicators of more severe COVID infection, while the decrease in lymphocyte count and decrease albumin, decrease in hemoglobin are common manifestations that are seen in patients who are affected with COVID. Now, I see regarding testing for patients, ICMR has been giving out guidelines on who should be tested, and we have very clear guidelines that all patients who have, all the symptomatic carriers of a laboratory confirmed case should be tested. All symptomatic healthcare workers should be tested. All hospitalized patients with any sort of severe acute respiratory illness, or SORI for short, as we call it, if any of these people should be tested, and asymptomatic direct and high risk contacts of confirmed cases should be tested within 5 and 14 days of coming into contact with the patient with COVID, has to be tested. So this is what the ICMR has suggested, and we need to follow that. And ICMR is time to time looking at this, and they may revise this, and we need to look at whatever the revised guidelines are. We should keep following that. And patients who have not been infected. So what about those who are not infected? So we have some of the infected patients. We've just seen what should be done, what measures should be taken, when we should suspect, and when we should screen them for the infection. But for the vast majority of our patients who have not been infected, this is what is true across the country. We have a large number of our diabetic patients who have not been infected. What we should do in such patients, we should see that they intensify their metabolic control. They should also continue with their blood pressure and lipid medication. They should not be concerned about the use of any of these medicines like ACE inhibitors or ARBs. If they've read it somewhere and they're concerned about it, we should allay their anxiety. We should mention to them that this is to be continued, and this is important for maintaining a good metabolic control. And patients with diabetes, particularly those with high risk, are particularly at high risk for metabolic disease. And when they and those who are infected by the virus should be screened for new onset of diabetes. So all those who get infected also with COVID infection or non-diabetic also should be screened for diabetes. And our patients with diabetes who are not infected, we should try to see that they maintain optimal control, and see that they have lesser risk of, while they stay protected at home with all the following all the recommendations that are there for their hand hygiene and for the social distancing and all these things. They need to continue doing that, and at the same time maintain a good glycemic control. Now, let us look at some of the consensus recommendations that have come out for COVID-19 and metabolic diseases. I'll quickly take you through the recommendations on which have come out from IDF and other organizations. Even the RSSDI came out with the recommendations. So what they have spoken of is prevention of infection is very important. So patients should maintain optimal glycemic control, optimization of the current therapy if if they have not been on good control, we should optimize their treatments and see that they should not prematurely discontinue any of these therapies. And we use the model of telemedicine and connected health models as much as possible to see that they remain isolated, patients remain isolated, and they don't get exposed to the infection. And in the intensive care unit, I mean, what are the therapeutic aims? So these are important in order to prevent infection and to optimize the glycemic control. For patients who are infected in the inpatient setting and who are in the inpatient setting, we need to see that their glycemic control is optimally managed, and we need to see that they have frequent monitoring of their glucose, electrolyte levels, pH, blood ketones, and beta hydroxybutyrate, and they should preferably be on intravenous insulin therapy rather than any of the oral agents that they might have been. That should be stopped, and they should preferably put on insulin. And for those who are on insulin, we should see that insulin should never be stopped. Blood sugar should be checked frequently. Plenty of fluid intake has to be ideally maintained, and their ideal blood sugar level should be maintained between 110 to 180. That has the best outcomes. If they are hyperglycemic, then we should adjust their blood glucose levels, monitor them accordingly. When the levels are more than 270 or more than 300, we need to do it every 2 hourly, but otherwise we can do it less frequently. And we need to prevent diabetic ketoacidosis because there is a higher risk of developing diabetic ketosis. It's been quite clearly seen in patients with type 1 diabetes that they can get metabolically decompensated and go into ketoacidosis. So that has to be looked at properly. Now, as compared to the type 1 diabetics, what about the type 2 diabetics? What should we do about their medications if they get infected with COVID infection? So, with regard to two of the medications, there has been little concern, that is metformin, because we know that this metformin, which is a very safe medication, which is a first-line medication on which most of our patients are already using this medication. We know that dehydration, lactic acidosis can occur if patients are dehydrated. So, hydration is the key in all our patients who are on metformin, and we may have to sort of revise our prescription of metformin if the patient needs to get admitted to the hospital. Similarly, the SGLT2 inhibitors are another group of drugs which are otherwise having a significant cardiometabolic benefit amongst our patients with diabetes. We know that we have a lot of evidence today about the cardiovascular benefits of these drugs, the renal benefits, but we also know that these drugs can precipitate the development of euglycemic ketoacidosis, or when there is some amount of dehydration, or when there is a metabolic acidosis happening. Otherwise, we should be careful in these with the use of these drugs. So these are the two concerns that should be there when the patients are getting sick and getting admitted to the hospital. We need to look at stopping these two medications. With the GLP-1 analogs, which are injectable preparations, again, what we what we know is that many of them have been shown to have cardiovascular benefit, cardiovascular advantage, but at the same time, dehydration is again a concern in patients who are on GLP-1 analogs, and that can lead to severe problems. So that again has to be, their use again has to be revised in patients who get admitted with COVID infection. While the DPP-4 inhibitors are generally well tolerated, and they can be continued safely without any concern, because we know that they have particularly drugs like linagliptin and tenligliptin we don't have a significant concern of the use of these drugs when even in significant renal impairment, while with milder renal impairment and even moderate renal impairment, vildagliptin, sitagliptin, and saxagliptin continue to be very safe drugs. When it comes to the use of insulin, we need to primarily depend on insulin in patients who are hospitalized for COVID infection. Regular monitoring of blood glucose is very important, and insulin use should be continued, and we should switch to insulin in those patients who are not able to maintain adequate glycemic control. Now, coming to the management of COVID infection itself, we know that today prevention of infection is the most important aspect. For those who are infected, we need to provide supportive care. We don't have a very clear message regarding which of the drugs is going to work very well. Hydroxychloroquine has been used. Remdesivir has shown a very good promise in the recent trials. It has shown that remdesivir is working particularly very well even in patients with severe infections. It works by decreasing the viral replication within the cell. And the other drugs which have also been tried, the combination of ribavirin and lopinavir, and then we have many other drugs which have been tried. But I think we have seen promise with remdesivir. Hydroxychloroquine showed initial very good results, and so these are the drugs which have been used in managing patients with. While convalescent plasma has also been shown, has been tried, and the ICMR prospective study is going on. We need to look at what the outcome of these patients is. We still need to look at the data, which is going to be published very soon. And if you look at the long-term follow-up, patients who recover from the illness with the SARS or COVID infection, they can have long-term metabolic implications, alterations, and we need to continue to monitor the metabolic profiles. And so, in a nutshell, if I have to summarize what I have said, I would say that good glycemic control with whatever therapy that is being used till now. If the patient is well controlled, continue with the same therapy. If the patient is not well controlled, then try to get him under good glycemic control, preferably fast, preferably sooner than later, and do it with insulin whenever feasible. And considerable care is required in terms of managing the fluid balance and potassium balance, particularly in patients who get admitted to the hospital. This is also very important feature. Maintaining their metabolic status is very important. I think will the tight metabolic control lead to better outcomes? Yes, we have some evidence for that. We have this paper from China showing that the management of patients with diabetes was not very optimal in this group of patients which they analyzed. And there's another retrospective observational study from the US which looked at more than 1,000 patients admitted in 88 US hospitals. And what they have found from this analysis of these patients is that patients with uncontrolled hyperglycemia had a longer stay in the hospital compared to the other group which had which had better glycemic control. Patients with uncontrolled hyperglycemia also had a higher mortality rate, and higher mortality rate in patients with diabetes with uncontrolled hyperglycemia against that is 28.8% mortality as compared to 6.2% mortality in patients without diabetes or hyperglycemia. So clearly, it is seen that the diabetes itself is a important risk factor, and also the level of glycemic control is also important risk factor in deciding not only their severity of the illness, the duration of hospital stay, and the final outcomes. So it is important that we act soon, keep all our patients well controlled, so as to see that if they get infected, then they should have a better outcome. And while highlighting to them or while emphasizing to them about all the precautions that they need to take to prevent infection. So in summary, I would say that COVID-19 outbreak has had a severe impact on the healthcare, including patients with comorbidities, particularly these patients who are older with comorbidities, and a strong association between diabetes and COVID-19 infection, with diabetes having a significant impact on the outcomes. And practical recommendations should be managed, should be followed in managing these patients. Thank you all for the very patient hearing. I'll be happy to take any questions along with my co-speaker after the session.
Thank you. Thank you so much, sir. It was a wonderful presentation. And I have access to the question link. So what we will do is I'll read out the questions later after the second session.
Yeah. So we'll do it together.
Yeah. So we will do it together because questions are very much overlapping also. I keep going through them. So they are on hypertension as well as diabetes. So we'll take it at the end. So thank you so much once again. Now for our second talk, we have Dr. V.C. Chauhan, who is the interventional cardiologist at Atmajyoti Clinic and also a visiting cardiologist at the Bahilal Amin General Hospital in Vadodara. So we are blessed to have you, sir, for this talk today. And you will be speaking on the hypertension management in COVID pandemic. So I welcome you once again and request you to take us through the talk.
Yeah, can you hear me well?
Yeah. We can.
Because see, I don't have that speaker.
Yes,
or
sir.
anything.
I can hear you.
Yeah.
Yes, I can hear you well. Now you will have to share the screen.
Yeah, I will share.
Yeah. Okay, sir. I can see you.
Initially, it is always the issue. How to...
Yes, yes.
The green button, sir. The green arrow, sir.
Yeah. So can you see my slides?
No, not yet. The green. You'll have to press the green button, green arrow on the.
No, that's what I did actually.
But it's not yet come.
Oh, okay.
No, no, sir. We can't see. I mean, we can't see the presentation.
So I applied the same green button which is down in the center.
Yes, share screen. Yes.
Yeah, that is what I did.
Yeah, but you'll get an option of all the this thing on the screen. Then you
files.
have
Files. Yeah.
the files that open.
Share all. Yeah, I did the same thing. Share all.
You have to double click on the presentation.
Okay, on the presentation.
Yeah, one which is seen on the screen.
Now can you see?
No, sir, not yet.
1 minute, huh? See, when I press on this, it shows share the screen, but then nothing happens. Yesterday it happened very well.
Okay. Okay.
I double click on the share the screen, which is green color in the center. Yeah, no, still you can't.
No, sir, we can't see the presentation.
So it is share screen, and once you click that, the
Okay, I can
all
whenever I
options
do
come in
this.
on that.
Yes, sir.
You get all the options. In that, you double click on the presentation. So then the presentation will get shared.
Double click on the
When you
presentation.
click on share
Yes.
screen, there are different options that come.
Okay.
Okay.
Now
In
can
that,
you
you
see?
go to the presentation.
Yeah. Now can you see that?
Yes.
Yes.
Now
yes,
it is come,
Yes.
sir.
Yes.
Oh,
Just
okay.
do
So
the
see, it's a
yeah.
little different actually.
Okay. Okay. No problem.
Screen share. I mean full screen. Yeah.
Okay. So sorry for that. This is in spite of doing so many webinars. So I think this is Chinese things which makes us little fun of us. Anyway, first thanks Dr. Rakesh Sahai for very good knowledge. And even if I read a lot about diabetes, I learned a lot of new things today actually, because every time we attend any lecture, there is something new to learn. So today I'm going to talk a little bit about hypertension, which is another comorbidity. And I think basic principles are more or less same as they were with diabetes and COVID, hypertension and COVID. So there's not much difference. But I would say that hypertension, as all of you know, is one of the diseases with highest mortality, more because of ultimately cardiovascular disease and stroke. Unfortunately, India has an increasing number of hypertension, and now we are in endemic for the COVID. So when these two are together, we know impact is too high. Fortunately, due to some unknown reason, mortality of COVID in India is very less. But in Gujarat, in our part, unfortunately, it is relatively high, Gujarat and Maharashtra. And here, whatever patient have died, you see, they are having either hypertension, diabetes, coronary artery disease, or some comorbidity. We saw even young people dying if they have high blood pressure. So definitely there is some relation between the two, and I'll see how they impact each other. Now, before that, I'll just like to say, just few days ago, like in March 2020, there was a hypertension guidelines by the Indian Society of Hypertension. And unlike Western society, we are going to have more impact with hypertension, like early onset, maybe decade earlier, more increase in rural urban both. The divide is decreasing actually. Clustering of multiple risk factors, where patient hypertension is diabetes as well. There is a lot of seasonal variation in blood pressure. That's why we have to change medicine also accordingly. Overall, average blood pressure level is increasing. In spite of all this thing, we have definitely low awareness, low treatment, and very few people are actually well controlled with diabetes. And we see many people, when they're diagnosed for the first time with a high blood pressure, they have already hypertension-mediated organ damages. So there are many issues that we are suffering as a Indian people. And you can see, just in last 2 decades only, ischemic heart disease, that is along with hypertension, has come number one cause of death, mortality, and morbidity. So we are developing country. Once upon a time, infectious disease was the highest cause of morbidity, but now no more. Even in these developing countries, even in urban and even in rural area, ischemic heart disease has increased. So that's a big impact we have. And as I rightly mentioned, you can see that the number of patients or hypertension prevalence is increasing very significantly over the last few years in urban and rural both. Before that, I just like to just a funny slide to show the coronavirus. I would consider coronavirus like a politician. I would say both of them, there are a lot of similarity. Both of them, they are invisible and silent. Of course, I'm not talking election time. Both causes havoc. Both are pandemic. You can see them everywhere. And most important similar features, both of them, they kill their own host. So that is a bigger problem that we are facing. And still, many people do not bother about them. We don't take them seriously. They mutate quite often and they are very unpredictable. They change their color each few days, and that's why we are confused. And when there's a presence of comorbidity, they are more dangerous. As for example, if there's a COVID and hypertension, COVID and diabetes, then that makes different difficulty. Like if our politician gets joined hand with the mafias, as for example. Of course, there are some difference. That virus will go away within 2 or 3 years with vaccine or medicine. We have no answer remedy for politician. That's bad thing actually. And politicians definitely become louder whenever there is a uh, any election time. So I'll go into little detail about understanding gravity, which Dr. Rakesh has very well said. So there's no point in talking about gravity. It is grave, and with lockdown off, and our people being so carefree, I'm sure that is going to cause a problem. Fortunately, our mortality is less than 1%, and that is really big blessings. And I think we are definitely going to get herd immunity. And maybe in 2 years, we will forget that we had similar like this, and everyone will be back to what they are now, not what they were before the COVID era. But there is definitely some correlation with hypertension and COVID. So that is what I'm going to talk about. All of you know that angiotensin 2 plays very important role. I think angiotensin 2 plays very important role, and till this time we had a lot of knowledge about angiotensin 2 receptors, mainly in kidney, heart, and the peripheral vessels, which are responsible for causing hypertension, all the sequences and interrelations between these diseases. Later on, we also realized, as Dr. Rakesh has very nicely said, that there are AC blockers, or rather angiotensin convertase have 2 receptors, even in the pancreas and adipose tissues, and even in mast cells. So there are many places where we see these cells, and they play a very important role in pathophysiology of many diseases. When COVID came, I think that basically the problem is what I'm doing is my I think it is too sensitive that it causes this problem. So it's basically, see, there's definitely a very big correlation we have noted from various registry or various studies between hypertension and COVID. And though the prevalence of hypertension is COVID is not more, or vice versa, once a patient gets COVID, if he's hypertensive, his morbidity and mortality is more than compared to a person who is non-hypertensive. So that is what we have very clearly seen from Chinese studies and later on Italian studies as well. So amongst other comorbidities, other than diabetes, hypertension is another biggest comorbidity, almost in 30%. The reason why there's a pathological link is more or less similar to as the reason that we have explained with the diabetes. As for example, ACE2 receptors, which are expressed not only heart and blood vessels and pancreas, but they are also noted to be in the lungs. And they play a very key role in a lot of pathophysiology that we are seeing, including hypertension, heart disease, but also COVID as well. And as very nicely Dr. Rakesh said, that coronavirus is first, they join with their spike protein with the ACE receptors located on the cells, mainly endothelium lining the lungs and many other tissues. And whenever they join there is a down regulation of ACE2 systems. Now, ACE2 is more or less helpful to prevent the side effects of RAS. So when they are down-regulated, theoretically, there should be more harmful action of RAS activity and there should be activation of RAS system. So on that sense, probably ACE inhibitors should be more helpful. But there are views which are against exactly opposite. And that's why we are confused whether we should use them or we should discontinue them. And a lot of messages had come on WhatsApp and other groups regarding whether we should stop or discontinue. So I just tell what are the recent consensus regarding whether we should continue using ACE inhibitors or ARBs or we should stop them. So these are the main issues. So as you say, ACE is involved in SARS through its function on corona receptors. And when they bind with the ACE spike proteins, they get entry into the lungs, tissue cells or alveolar cells, and that is where it causes damage. And then they multiply and we know what happens afterwards. So this is the pictorial diagram, which is very nicely shown with 3 dimensions by Dr. Rakesh. So I'm not going to detail. But as far as lungs and blood pressure is concerned, I will just mention it very briefly that AC1 activates RAS systems. On the other, AC2, they counters RAS activation. So AC2 is a functional receptor of SARS. Whenever there is SARS infection, the hypothesis says there is a suppression of AC2 with activation of RAS system. So in that sense, theoretically, the AC inhibitors should be the first choice and this should be helpful. The people we have an opposite of AC inhibitors, they said that AC inhibitor suppresses AC2, so that increases AC2 receptors and they are the site or substrate for the COVID. So these are two theoretical hypotheses which are both against each other. And we didn't know which is correct because it's very difficult to prove or disprove at this particular moment. But which is correct out of two, we have to see some of the studies and examples, and that will tell us. As for example, definitely there's controversial relations. But this study from Italy shows that AC2 receptor expression is downregulated whenever there's SARS infection. And that resulted in activation of ARS RAS system, and that causes ultimately pneumonia progression. So theoretically, anything which can help suppress AC2 RAS activation, like AC inhibitors, should be helpful. This is another study which shows angiotensin II converting blockage or ARBs or AC inhibitor treatment may have controversial role. One, on facilitating infection, on the other hand, reducing the pathological inflammation. So that's why two views I'm just deliberately showing opposing each other. So actually what happens? Theory is theory. Now there are many studies which shows in a patient who is a corona positive compared to corona negative, and there are 6 groups like patient with corona positive, corona negative, no hypertension, hypertension. Hypertensive patient again in 2 groups, those who are AC ARBs or those who are others. So these are the 6 groups that was compared. Obviously, patient with no hypertension and no corona has a best prognosis. Amongst corona patients, those who have hypertension have definitely worse prognosis compared to those who do not have hypertension. But amongst group of patients who were hypertensive, if they were treated well controlled, prognosis was better. And amongst that, if they were on AC inhibitors or ARBs, probably mortality and morbidity was less, and that was seen by some of the studies that is seen later on. But here you can see below in the slide that those patients who were on AC inhibitors or ARBs had relatively low less prolactin, procalcitonin, and many other infection markers, probably indirectly suggesting that they are more protected compared to what theory I had mentioned before. And there are many studies, but just to show few, this study shows that in conclusion, the currently available data shows that we should continue this treatment if patients are on this. Of course, many people also suggest that if patients are some other antihypertensive, we should not replace them with AC inhibitors or ARBs. But if there are indications, like patient develops heart failure, or some of the specific indication AC inhibitors or ARBs, then it should be added accordingly. Same way, if there are indications to stop this medicine, like patient on AC inhibitors or ARBs, and they are developing septic shock, hypotension, renal involvement, these are the conditions where we have to stop this medicine. So indication to start medicine, initiate the medicine, or discontinue medicine remains more or same, irrespective of whether patient is COVID positive or COVID negative. Only importance here is if patient is already well controlled blood pressure with any medicine, if they are on AC with ARBs, the prognosis seems better compared to other medications. So that is the ultimate conclusion that we should continue it. I will not go into detail about theories because that is what we have already seen. And this is similar thing which has been already repeatedly said before, so no point in going to details. But so what are the guidelines and recommendations at the moment? At this moment, the Council of European Society of Hypertension or Cardiology suggests strongly to continue medicines that they are on, whichever medicine they are on. ESC guidelines, European Society of Cardiology guidelines says that definitely there is increased mortality if patient hypertension. More it's because hypertension occurs in elderly people. And being elderly, like each few decades, mortality because of COVID increases. Same is true for hypertension. And both disease, hypertension and old age both run together. So it's very difficult to know. But as I previously mentioned, older the person, more is the risk. But if the associated hypertension risk is definitely multiplied. So at the hypertension increases the risk of getting COVID infection, but definitely it increases the risk of complications, and especially chance of going into ventilator if they have high blood pressure. So that is what I think. So at the moment, there is evidence to change the use of AC inhibitors or ARBs. We continue them same way it was before pre-COVID era. There are many studies. As for example, it says should not discuss symptoms of ARBs just because you are concerned that patient has COVID infection. Even if they have severe infection, if the blood pressure is high, we continue them. Only reason for discontinuing is, as I mentioned, hypotension or some of the other specific contraindication to these medications. Now, how do you manage isolated patients? That's a very important issue here. Now, when you have many self-isolated patients, so at this moment, I would, as a cardiologist, recommend patients to use home monitor. Advantage of telecommunication that we are now, what we are doing at the moment. So this is what we encourage at the moment. Of course, when they are in ICU, sometimes invasive ventilator will guide our doctors a lot. But that's also advantage. That's how you can be away from the patient. Any patient is COVID positive, even if with PP mask, there is no 100% guarantee. It's better that we should monitor patient, see the patient from distance of at least 6 feet or so. That is very important. Like in pre-COVID era, we are bothering how to measure the blood pressure, what are the real techniques and other things. Now that issue is out, as far as COVID era is concerned, patients should be taught how to monitor it. Yeah. Yeah, that's what I say. Yeah. Now it's gone. See, that's what happened. It was basically the pop-up. Okay, good. That's what I thought. I didn't know how to. Yeah. So in COVID era, we have to measure blood pressure with BPV in gloves, and that's not always very easy. If you have big OPD, it's not very convenient and very common. Those who have done OPD with PP, you know how difficult it is. We perspire actually more than the patient. So home monitoring is stress. Of course, it's very difficult to teach patient now home monitoring. But those who are already into home monitoring, we have to change the way we are thinking a lot. Like telemedicine was not advisable just few months ago by our ICMR or Indian Medical Council. Now they are supporting it. I hope they would have done it 10 years ago. Probably situation would have been very different. So we have to very strongly suggest telecommunication. I think that should continue even afterward. Like you have a blood pressure patient who comes first time to you, or diabetic patient first time, you investigate properly, you thoroughly examine them, find out what is the problem, comorbidity, teach them about diets and everything. And then probably at follow-up, you can do the telemedicine. Like in diabetes and blood pressure, both the disease, teleconsultation on follow-up is possible. First time it may not be, but afterward, yes, it is possible. Of course, if they are very sick patient, they have to be in the ICU with automated cuff monitor. Now, tight control definitely is required, but there is no direct correlation. The tighter the pressure control, better is the outcome with COVID. But definitely, if blood pressure is uncontrolled, prognosis or mortality is high. So it is not clear whether blood pressure alone is risk factor to get this infection, but most likely it is not. But once infection occurs, blood pressure makes patient much more vulnerable. More the blood pressure, more the multi-organ involvement, more the associated comorbidity, poorer is the outcome. That is very clearly seen. So blood pressure control remains very important consideration. It doesn't matter which medicine, but it is important consideration. So AC inhibitor 1 activates RAS system, while 2 counters the systems. And whenever patient has SARS, AC2 receptors are the functional receptor for the SARS. So that was basically a main theory and argument for this that we have already discussed. I'll just recommend, do not change from AC inhibitors or ARBs to beta blockers, who has his own side effects. Do not change to AC inhibitors or diuretics, they have their own side effects. Stick with what medicine you have. Now, another very important point to be considered, this is a very golden period for us to teach our patient if they have hypertension, diabetes, or the lifestyle disease. And I have seen that Corona has two impact. It has caused lockdown, and lockdown has a lot of impact on our social life, the way we are living. And I have seen three type of people. One, who continue the same lifestyle. Number two, their lifestyle improves significantly because of time they get to stay with the family, less of tension and stress. And number three, some people had worse lifetime. They get so panicky, they could not remain isolated. They feel lonely, and they were social outcasts, whatever it is. But we had these three type of impacts. So we have to educate our patient with repeated phones and what it is that this is the best time to manage lifestyle related diseases. Other than corona prevention, we have to control other lifestyle diseases. So I would suggest just continue same daily styles, sleep at the same time, wake up at the same time. For all our doctors and even to the patient, in a limited way, teleconsultation and continue other healthy thing that we are doing. Obviously, this is a time that we can help control our stress significantly. We should not continue our bad habits that we had before the corona. I have seen many people glued to the telephone or to the WhatsApp and other thing, and that has caused more stress. So many people, they get stressed when they go to office, the blood pressure keeps up. This is a time that you're away from your boss, and that should help you reduce the pressure. Of course, there are many who are more uncomfortable at home, and they have more stress at home, and their blood pressure will go out of control at home. So don't do anything which makes your life difficult, which makes it go up. See that lockdown does not result into these things or these things. Lockdown is a time to make yourself back to the normal and healthy life. No addictions like this. Other contrary, there are so many positive effects of corona, which we probably will see later on. All the rivers will become clean, atmosphere will become clean, pollution is gone. In China, they said that pollution has gone down so much that actual mortality has gone down. Pollution was killing more patients in the same duration than the corona is killed. So overall mortality has gone down. And let us see the lifestyle disease go down. It will be a big thing. So we have to learn how to live a balanced life. That is, and lockdown has its own positive effect. Corona has its own positive effect, and let us see that it would ultimately be benefited to our patients as far as lifestyle disease is concerned. So COVID can kill, but at the same time, COVID kills means corona induce improvement in lifestyle diseases. That is what I'll say, and I think I will end here.
Okay, thank you so much, sir. Thanks a lot. Thanks a lot. This was a very wonderful presentation. So I'll read out the questions. We have around 6, 7 questions. So I hope I'm loud and clear.
Yeah, yeah.
Yeah. So the first question is: should patients with diabetes and hypertension take any measures to prevent COVID-related mortality? So, are there any measures which they can take?
Yeah, I think what we are highlighting is that we need to keep the diabetes under control, and they should be at I mean maintaining their diet and lifestyle. So a person who is diabetic and hypertensive, if he's well controlled, maintaining a good lifestyle, his immunity is better. He's likely to have a less severe course of infection in case he develops the infection. While doing this, he needs to also take all measures to prevent the infection. And I think that's the message that we are trying to give to all the doctors and to our patients.
Sure, that sounds sufficient. Now, the second question is which one is better, DPP4 inhibitor or SGLT2 in controlling hyperglycemia in COVID 19? This is very interesting for us also.
Yeah. So what we were saying is that the SGLT2 inhibitors have recently a lot of evidence accumulated regarding their cardiometabolic safety, the renal safety, and we have no not only safety. I mean the benefits we are saying. The DPP4 inhibitors have also shown the safety. Safety profile has been shown. I mean in the sense that the cardiovascular outcome trials have shown that inhibitors are safe. The SGLT2 inhibitors have additional benefit of reducing the mortality, the cardiovascular mortality, and cardiovascular disease burden. So, what we, I mean, so in patients who are on SGLT2 inhibitors, they need to continue that. In case they develop infection, in case they develop a more severe infection, then they need to sort of we need to stop them and switch over to other medication. And in such situations, insulin is the preferred choice. Uh, while those on DPP4 inhibitors, I mean the DPP4 inhibitors, as I mentioned, that because of the that we are saying here, that they could have the potential benefit of reducing the virus entry into the cell also by inhibiting the DPP4 enzyme, which could also serve as a sort of a receptor for the sort of receptor for the entry of the virus into the cell. So it can have this potential benefit, but it has not been clearly shown that this is the receptor that is working for the SARS COVID-2 virus. So I think basically we don't need to worry about changing any of these medications in patients who are not infected. We need to optimize the glycemic control. Either of them can be used perfectly well. And only when a person gets infected and we are managing the diabetes in that scenario, we are a little concerned about the use of metformin and SGLT2 inhibitors, particularly when they get metabolically decompensated. I mean, they get into a problem like having a more severe infection, or they're going into ARDS, they're going to a more severe infection, a severe manifestation, then we need to stop these and shift to insulin in this.
Okay, sir. Thank you. Now, this has been discussed pretty well, I think so. But there's still there a question which says that are ACE inhibitors better than ARBs in the current scenario?
Yeah, sir, Doctor.
See, this question is permanent questions. Yeah, sorry. This is a permanent question whether is it COVID era or non-COVID era. So COVID era does not change that particular things. See, there are more studies at the moment suggesting AC emitters better in heart failure patients. But now with another heart failure medicine that is coming up, it is considered number one. As far as AC inhibitors ARB is concerned, I do not see any difference. Though there is, as far as trials are concerned, a little bit in favor of AC inhibitors. But in my practice, I still use ABs much more because I have seen that 60% Indian patient, they develop such a nasty cough that they actually get really troubled by that. So as far as mortality is concerned, maybe ACE is slightly better. But if patient discontinue it, all the benefit is gone. So theory, practically, ARBs are better. But COVID era does not make any change whether this is better or that. That remains exactly same as whether it's COVID or no COVID. Indication to start, indication to stop, they remain exactly same.
Theoretically, if you see, theoretically, actually, if you just look at the theoretical aspects, it is probably thought that ACE inhibitors increase the ACE2 expression to a greater extent. So whether increase the virus entry to a greater extent than ARVs was a concern which was there. But what we have also seen is, as I've also spoken, and Sir has also, Dr. Chauhan has also highlighted that this ACE2 expression actually has some benefits also.
Exactly.
So apart from the virus entry, whether it increases the virus entry or not is only hypothetical, but it has other benefits in terms of reducing inflammation also. So and when you look at the evidence, there is no difference. So
yeah, exactly. On the contrary, it shows more in favor of continuing it. Of course, in COVID era, there is no comparison between ACDBs and ARBs as far as COVID era is concerned. So the same theory that we discuss again will continue for the differentiate between the two.
Before we had any data from that hypothetical discussion was there that increases the ACE2 expression more, the ACE inhibitors or the ARBs increase the ACE2 expression more. But that has been clarified now with the data.
Okay, that is enough. So the next question says, what is the opinion on hydroxychloroquine prophylaxis in COVID-19?
Yeah. See, basically, this is again another controversial topic. Like, see, as for example, when Donald Trump said this is going to be a life change, there are conflicting results. Like just recently today, I showed WHO does not recommend using hydroxychloroquine as a prophylaxis. On the other hand, Mumbai, there was one study in a police, as for example, 1,000 police, so 500 plus in one group and about little less in another group. And they said that mortality of police people who were taking hydroxychloroquine, mortality was 0. In other group, it was 9. Now, there are many such studies which conflicting results. So I don't know whether it should be used or not. But if someone want to use, like in Gujarat government, there all COVID patients are given hydroxychloroquine. And we have seen that side effects are not as much as they are actually stressing. If patients severe hypokalemia, they are already on a medicine like amiodarone, sotalol, anything which causes QT prolongation, all congenital QT, then only we have to worry. Our rheumatology colleagues are giving hydroxychloroquine twice a day for many years for the patient with rheumatoid arthritis, other diseases. The side effects are not as big concern as is highlight. So what happens? In media, they give extreme news on either side. They want sensationalization. On one end, they write it saves the patient, it's a cure. On the other end, they say it's totally useless. Actual says it's something in between. It's not as harmful as side effects are concerned, and it is not totally curative. In fact, 90% patients, they recover from the corona. So we don't know whether using this will make a huge mortality benefit or not. But if you take, it's not bad either. So my answer is neither way.
To add to that, I would like to highlight the fact that hydroxychloroquine has also been recommended for management of diabetes. Since
really?
2014, the Drug Control of General of India, the DCGI, has approved hydroxychloroquine as a drug for management of diabetes also.
But in which condition? I've never seen anyone using it.
It is recommended as an add-on to metformin and sulfonylurea for patients who are not controlled with these two drugs. Addition of hydroxychloroquine has been recommended, and the mechanism by which hydroxychloroquine has been thought to work, is because it reduces the insulin degradation and provides this acidic environment which prevents the degradation of insulin and prolongs the inflammation. Second thing is, apart from that, it has the anti-inflammatory effect because inflammation has an important role to increase diabetes. So that is the way it is thought to work. And the observation actually came out from data on the long-term users of hydroxychloroquine for rheumatoid arthritis or SLE. They had a much less instance of new onset of diabetes as compared to those who are not.
Oh, that's
So that
something very new.
That is something different.
And now it is actually from 2014, it is recommended as a drug in our country. And we have some of our patients actually who have been on hydroxychloroquine. So we have not seen any problems with the use of hydroxychloroquine, and as was highlighted that particularly those drugs in combination with those drugs which can increase QT interval, that's the problem. So we have to be careful in such scenarios. And some of the problems that were reported, I mean, probably when we heard of hydroxychloroquine and people started using it, probably it was used along with azithromycin, which was causing the QT prolongation.
More QT prolongation.
Yes.
Maybe the
But see, there are two views regarding this. One is prophylactic role, which is actually used by many government agencies, like all medical officers or frontline workers are given hydroxychloroquine prophylaxis. So that is one thing, probably reduce the corona infection. Second is, if you get infection up to the throat, if you give hydroxychloroquine, because of the side effect and the cytokine storm may be reduced. So we don't know which is correct. With the prophylactic, some theory and giving is not a contraindicated. So I don't know whether we should continue. So initially I started taking it, but then discontinued. I'm not taking at the moment. I don't know what others are doing. But many doctors in Baroda started taking it.
Yeah, the reason
Donald Trump is taking daily.
So the reason why it was thought to have an effect is that it reduces the viral replication by providing that acidic environment. So it reduces viral replication after the entry of the virus into cell. So that or it also reduces entry of the virus into cell and replication. That's what is question mechanism by which hydroxychloroquine is thought to have a prophylactic action. But
Okay.
it has not been proven anywhere, very clearly proven.
True. Absolutely. Absolutely. So the next question
If
is
they
what
are
make
not harmful. Yeah. Well, sometimes if some medicines are not harmful, their potential probable advantage is not bad taking them, because it is at least some placebo, people are concerned and it may have some favorable effect. I don't know, but just some placebo effect is definitely there.
Okay, sure. So we'll move to
Because
the
see,
next
it's
question.
mask. Like many people, when they put on mask, they feel now we are assured.
Okay, sir. Thank you so much. So moving on to the next question. So next question is what makes a diabetic person potentially more susceptible to viral infection in general? Yes, sir. Can you hear me?
Yeah.
Yeah. So what makes a diabetic person potentially more susceptible to viral infection in general?
Yeah, actually, what we can say is that they're not susceptible to infection. I mean, in the sense, the infection depends on, exposure and all that. But
Correct.
But diabetics tend to have a effect on their immunity. The metabolic control can have an effect on their immunity. And therefore, we say that, the infections are more severe in diabetes. And many times it can be because when we say the term that susceptibility to infections, it obviously means the severity of infection more. It's not the exposure. They are more likely to get exposed or more likely to get infected. But it is once they're exposed, they're more likely to get manifestations of the disease. So because we know that many of these diseases, the viral infections, can be apparent in the sense the infection can be asymptomatic. So they may not have. If you look at diabetics versus non-diabetics, non-diabetics may have, many of them may be asymptomatic or may not develop any of the symptoms. Diabetics are likely to develop symptoms, and therefore we say that they have more manifestation of the disease.
Thank you so much, sir. So we have one last question left, which talks basically about a cytokine storm. So there were two questions which people want to understand what is a cytokine storm, and the second is what therapies are available for the cytokine storm management in COVID-19 patients with lung inflammation.
Now see, wherever there is over-inflammation, our body, whenever there is any organism, any attack from outside, whether it's virus or bacteria, we react by inflammation. Inflammation actually is a safeguard against any outside invasion. But when the inflammation is out of control, that itself is harmful to the tissues, especially in patients with COVID, when there is a overreaction of inflammation and too much inflammation, which involves the lungs and other things, it creates what is known like ARDS like symptoms or COVID SARS symptoms, middle respiratory distress syndrome type of situation. And that is definitely harmful to the patient himself because his saturation goes down, and then ultimately vicious cycle, multi-organ development takes place. There is no specific treatment for it, but there are certain different opinions. For example, America initially they put ventilator too fast. Now they realize it should not be put too fast. It should be high oxygen, and only as a last resort, dire resort, ventilation should be used. That's one thing. The role of steroid is always, as usual, very controversial. Similarly, the role of plasma therapy, which may probably help overcome cytokine crime, but I'm not very sure whether any of this medicine 100% proof. I'll ask Dr. Rakesh to add anything to this particular thing.
Yeah, as Dr. John has very clearly told us that it's a cytokine. The cytokine storm is a unregulated release of the inflammatory cytokines, which are actually trying to control the inflammation, and when they go out of hand, then it causes the damage. And what has been shown that the ARDS which was initially thought that it is the ARDS, and very early ventilation was thought to be good initially, but it was shown that it was counterproductive, and now people are looking at oxygen, and it is said that the other fact that has also come out is that there's more of this DIC type of manifestation with intravascular thrombosis being there, and the use of heparin is again highlighted because of this. So I think it's a cytokine storm. How best it can be managed is very difficult to say. Whether steroids have an effect, some people have said that steroids may have effect, but I don't think it is very clearly shown. It was harmful in the MERS epidemic. Steroids were found to have a detrimental effect. So it is the cytokine storm which is the major problem, and it is the people who develop this storm, cytokine storm, can end up with significant morbidity. And
Okay, sir. Thank you so much.
Just
so we have no
last suggestion is nothing to do with this
sure.
topic.
Sure.
But someone told me that when you use iPhone, you keep it horizontal. Like instead of vertical, make it horizontal. It will be much better. So just for the trial, if you can try to make it horizontal, that will look much better. Okay. That is what someone told me. Yeah.
Okay. Sir, actually, the vendor asked me to keep it vertical.
Is what keep it in they told me. Okay, you always keep horizontal. It will be much better. Now you can see the difference.
Thank you. No worries. Thank you, sir. Thank you so much. So, sir, actually, I'll thank both of you once again.
And very valuable.
Yes, sir, you're saying something?
I said Dr. Johan has given us very valuable insights.
Yeah. So I'll thank both of you once again. I'll also thank the participants, because there are a lot of enthusiasm and participation shown. Before even we started the sessions, there were 4-5 questions already posted. Now I'll request Mr. Vimal Varghese, who is our marketing head, to say a few words and say basically vote of thanks. So Vimal, can you please go ahead?
Very much, Dr. Abhay. On behalf, words are just not enough to say to both our eminent speakers, Dr. Chauhan and Dr. Hakizahai. Thank you very much once again on behalf of the entire IndiaBull family for taking time out of their busy schedule and taking us through this wonderful presentation. I would also like each and every participant. In fact, today we have more than 700 participants who have registered to this event. So thank you once again, doctors, and for the active participation. And we look forward for a continuous interaction time and again through this platform. Thank you very much, and have a wonderful day. On behalf of IndiaBulls, once again, thank you very much.
Thank you very much.